Hello? Leta yumvikana kubera ko twegeranye cyangwa akamyotinga
twakurikira dute se none
irafunze
turaba dukurikira ibyo avuga n'amagambo.
kandi isageze gutangira
ibyo kumva ni gushyiramo kuteri nushyiramo kuteri ndi kuvuga ntabwo ntiwategura
Adesso questi termini prima cosa del corpo che c'è
gutandukana gute
ari na mute ntabwo byakunda biraderanja kuko niyo yari mute kujya hano tukaba out of
sharing.
njyewe yangire nta kibazo umubanzira invitinga ndi wa mbere invitinga presentinga
Uriya yarambise ko ntawe arabise ko ntawe ariko arabikorera
n'amatelefone murayakuraho sound
bakora akantu warunyeretse kugira ibibazo
twagiye badufunga telefone
mufunga y'amatelefone
badinyitinge then mugasaba ikibazo ari ikibazo yego
Hello, good afternoon, everyone. As you are all logging in, we are pleased to welcome you on this session on training on hemophilia. I would like to request all of you to follow the following guidelines. Please change your names on your devices from ITEL 336 to your real names. This will help us in in participation and in order to receive your certificates. So for everyone having names such as names of devices such as Techno, please change them to your real names. I would also request you to mute your audios so that we don't interrupt the professors and consultants as they are giving us the sessions and trainings on hemophilia. Yeah, thank you so much. I would like to remind you all to change your names to your real names from device names as ITIL A36 to your real names, because this will help us in the participation and giving of certificates and following up on the participants, and also mute your audio so that you don't disrupt the professors and consultants as they're giving us the lessons on hemophilia. I would like to welcome the team that is going to give us the session. Welcome, Ange.
Dear participants to this training of physiotherapists, we thank you so much for having chosen this training. We are very happy to join you, and we are asking for your attention to what will be discussed in this training. First of all, I'd like to tell you that I'm Sylvester Orindabyuma, the Deputy Legal Representative of Rwanda Fraternity Against Hemophilia. And I'd like also to tell you more about Rwanda Fraternity Against Hemophilia. It is a national non-government organization which have been certified by RGB in March 2020. And this aims to identify and facilitate diagnosis and treatment to patients of hemophilia, to frame and advocate patients with hemophilia, to build the capacity of population of Rwanda and health professionals on care and treatment of patients with hemophilia. Fourth, we'd like to create multidisciplinary health community and committee in the framework of hemophilia. Fifth, we have to create networking with other organizations of hemophilia worldwide. And at the end, we'd like to facilitate patients of hemophilia to access hospitals and medicines. We have realized something, but not too much, because of COVID-19 interruption. But we are still struggling, doing our better to accompany our hemophilia patients. Among that, we have tried to join worldwide hemophilia organizations, and we cooperate with Novo Nordisk Hemophilia Foundation with a project of awareness and sustainable assistance and financial state. We also have a collaboration with AFH, Association Française des Hémophiles. That has helped us to maintain our social organization to help with transportation of hemophilia patients to hospitals sometimes, and to aware us about the content of the willing of World Hemophilia World Federation of Hemophilia. So they helped us to maintain good relations with the World Federation of Hemophilia, so that when we asked for accreditation, they gave us the accreditation in World Federation to ensure that good relations will help us to be in good ways of getting medicines which are very expensive in Rwanda if you go to the pharmacy to buy them. For example, one cure of factor 8 or factor 9 may cost about 14 millions, or when it is negotiated, it may just cost about 8 million. You see that this is very expensive, and it is not possible to get factors on our own payment. So we'd like to invite you to help us to make known this hemophilia disorder and conduct many patients you may just see anywhere in your environment to the CHUK, where they can be diagnosed and where they can also get treatment. CHUK, we can just get factors, and we can also make a diagnosis of hemophilia. Then we do like everybody to help us to avoid any kind of thinking of different citizens when they see some people with hemophilia. They think that they have been poisoned, or sometimes they can go contacting witchcraft system, thinking that they may just find there a care. Since we discovered that they are not practical, we have chosen to found the Rwanda Fraternity Against Hemophilia to aware many people in Rwanda and people worldwide about it, and to avoid that thinking, believing that everybody who is living with hemophilia will find a help and diagnosed and course.
Thank you so much. I'm the president of the RHF. That would like to thank so much the president of the RHF about the introduction and how we are going to right now I'd like to thank the therapist and how people can do that. Thank you so much. Hello?
Hello? Hello? Can you hear me? Hello?
Hello, we are hearing you.
Thank you so much. I was having issues hearing the previous presenter. So thank you so much. And I guess it's my time to also say something about how you can make sure that we are helping our patients with hemophilia. So I would like first to thank the president of Rwanda Fraternity Against Hemophilia for organizing this very important session that is intended to raise awareness about this issue of hemophilia, to discuss how we can all work together to help our patients with hemophilia. And I would also to thank our dear clinicians. I'm seeing that we are with Dr. Mab, who is, treating most of our kids with hemophilia. I'm seeing Dr. Masaisa, and all of you physiotherapists, and also those other doctors that I'm seeing here that are all involved in the prevention, but also in the management of this very serious disease. So let me start by saying that really hemophilia is a very serious issue. But once we work together, we can, our kids can really, our people can really live a normal life through early detection. Of course, early detection starts with awareness, and then we can make sure that we can really make a good early detection. So, and also be able to have a prompt transfer referral up to the, referral hospitals where the diagnosis can be done. But as healthcare providers from the lower level of the healthcare system, visit hospitals, health centers, what we can do is to make sure that we can have really, we can suspect, and once we suspect, and then be able to transfer on time so that the final diagnosis can be done, and then the treatment is initiated. Because once an effective treatment is initiated on time, these kids, these people can live a normal life and continue, working for themselves, but also their families, and also contribute to the development of our country. So I thank again, Rwanda Fraternity Against Hemophilia for this continuous support, for the advocacy they are doing, the awareness they are doing, and also, as Sylvester has mentioned, this very, very less important support that they are doing, bringing medicines in the country. As he said, and we all know, these are very expensive medicines, and if you look at, the capacity, the purchase capacity of our patients, it won't be really possible to have these medicines. So we thank you so much for the advocacy you are doing, all we are doing to support, to bring the treatment to our patients with hemophilia. So I won't really take long. I know I've seen the agenda. We have many measures. So mine was really supporting this initiative. We work with all of, the burden of this issue, but I think we should, we're gonna put much effort so that we can work together to put in place that is working with, of course, with all of you, physiotherapists, doctors, clinicians working from different health facilities. So, and again, let me also, let's say, highlight here the role of physiotherapists in the management of hemophilia, because there is medical treatment, those drugs that, those factors that can be given to prevent bleeding. But again, without therapy, even those patients, so that they can really keep, being physically active and also continue working. So the job you are working and you continue doing is really, much appreciated. So without, taking much time, and so my remarks were to thank the organizers of this very important webinar, to thank you clinicians, the great work they are doing, and also to tell you that Rwanda Biomedical Center, Rwanda Ministry of Health, we are with you. We provide any support available to make sure that we are really providing the appropriate quality care to our people with hemophilia. So thank you so much, and I wish you to have a fruitful webinar, and we are together. Thank you so much. I have concluded my remarks. Thank you.
thank you for your usual collaboration in treatment of hemophilia, and today your participation and wishes. We are working together to put a good quality of life for patients with hemophilia. On agenda, we are going to receive Dr. Aimable. If is not available, you can. If is not interruption of network is problem, but few minutes will be fine.
Hello, everyone. Hello. We're sorry for the inconveniences. We have a problem with the network, but Dr. Aimable is ready to give us the course on hemophilia. We can welcome him. We have technical and internet issues, but we are sorry for the inconveniences. Thank you.
Shall we start? Ladies and gentlemen, good afternoon. Welcome once again in our teaching session on treating hemophilia in Rwanda. What challenges? So my name is Hemophilia. I'm a pediatrician, a consultant pediatrician hemato-oncologist, currently based at CH UK, and I'm quite involved in managing children with bleeding disorder, including hemophilia and the other kind of bleeding disorders as well. But also we focus on anemia and cancer cases. So our presentation of this afternoon will be focusing on treating hemophilia in Rwanda. What challenges? But before going on challenges, we will be covering the basic knowledge on hemophilia. We'll be discussing how do we increase our index of suspicion of a case of hemophilia. What are clinical presentation? How do we come up with the diagnosis? What treatment option do we have in Rwanda? And the challenges. Unfortunately, we do apologize. There is again a technical problem that is being sorted. As you can see on we shared is the first slide. So we pay attention as we progress and sort this problem shortly. Sorry for technical issue. Let's take like 3 to 5 minutes to sort it out. Technical, sorry for this technical issue, but we do congratulate our technical staff who managed to sort it out. So I was saying we're gonna discuss treating hemophilia in Rwanda, what challenges. As I said,
We apologize for the inconveniences. We have a network problem and a technical problem, but they are working on it. We are sorry for those of you that cannot be able to get the sound. I think the problem is the sound with your devices, because the sound from the doctor is okay. The only problem is with the technical team on the presentation. We are sorry for any delays and inconveniences, but we are working. each one of you that still has names like F1 to work on changing the names of your devices. Thank you so much. Please change the names on your devices and also correct your names by writing your full names and not the names of the devices like phones and laptops. We are still correcting the problem. I think it's now fine.
Okay, good afternoon once again. Sorry for this technical related issue, but hopefully will not be raised once again. So as I said, we are going to discuss treating hemophilia in Rwanda, what challenges we face as treating physician, and as outlined, we'll see what is hemophilia, just for basic. What is the background of the hemophilia? What's the role of genetics? When do we suspect hemophilia? The basic investigations we should be request in the case we suspect the case of hemophilia. What are treatment options available in our setting? In the case we do not have it, what are basic intervention we should be doing when we face a case with hemophilia? Last not least, would be looking for complication because most of the patients might present only with complications. If there is any technical issue, please, if the slides are not moving as displayed, let us know timely. We can stop and resume at any time. And we would like to recall that questions will be asked at the end of all presentation. So if you're gonna get a question, please write it down. We shall have all questions at the end. So what is hemophilia? Hemophilia is defined as inherited hemorrhagic disorder that is caused by deficiency of factor either 8 or 9. As we draw your attention on inheritance model is X-linked recessive inheritance. That means all male exclusively will be affected. So the female will be always a carrier because most of the time they have only one single mutated gene, but in medicine, there is no white and black, always there is a gray. So not be surprised if you have a female with hemophilia, but it's very, very rare. The incidence of hemophilia is not rare as such. Worldwide, hemophilia A, out of 5,000 live births, you should have one case of hemophilia. Whereas when we compare to hemophilia B, around 1 out of 30,000 male live birth is hemophilia case. So referring to what we have in Rwanda, so if you know very well our population that is pediatric, referring to the last demographic data available is around 5 million. So imagine how many cases of hemophilia we should be having in Rwanda. Unfortunately, the case we have currently in our data is around 60. Referring to incidence, we should be having around 1,000 cases. Where do we expect to get the rest of those numbers? So question will be tackled at the end of this presentation as well. So as we said, hemophilia is X-linked recessive disorder that is made or characterized by deficiency of coagulation factor 8 that we call hemophilia A, or the factor that is lacking is 9, so we'll call hemophilia B. So the transmission, we said it is X-linked, but according to the new publication recently, we have found that 30% of new diagnosed children with hemophilia do not have family history. Either the mutation is spontaneous on those cases. So in the past, when hemophilia was being known worldwide, it has been known as royal disease. Why? So one of the royal family, the Queen Victoria, who was ruling England in 1837 to 1901. This queen had 9 children. Out of 9, 3 of them had hemophilia or had abnormal bleeding in that time. One of those 3 was a son, Leopold, who died because of extensive bleeding at the age of 30 years. You understand those the two daughters were carrier and transmit again that hemophilia in the siblings or the second degree family. So in England, they call that disease in that time a royal disease because it was found in the Queen Victoria that was known as a carrier. So what do happen when a carrier or a patient with hemophilia is married with another one? So as we said previously in 2 previous slides, most of time the carrier is mother because they have 2 chromosomes or 1 mutated gene. They will never show signs of abnormal bleeding. But when it comes to giving birth a boy with already a mutated gene on X, that boy will be having hemophilia and will have all clinical presentation as we're gonna see. So let's refer to this couple where the mother is already a carrier with only 1 X that is mutated, whereas the father with XY, his X is not mutated. So the probability of getting a son in this family or one disease child is 25%. So, but for all boys, the probability is having 50%. So if you can look on this pedigree, you can see the son, the first son is without hemophilia because has got the Y from the father and the normal X from the mother. The second child, who is the daughter, received one mutated X and another X is coming from the father. So this one will be a carrier. In other words, will not have any signs, as we're gonna see in the next slide. So the son who received Y from the father and a mutated chromosome X will definitely have hemophilia. So the fourth one is a daughter getting X from the carrier and X from the father will be normal. You can see the probability of getting a case of hemophilia if you have a mother. So there is almost 50% of getting a chance of transmitting a mutated chromosome. So what are classical clinical presentation of a patient or a child or an adult who has hemophilia? The only concern is bleeding disorder. So they might bleed anyway at any time, but most of the time it might be either related to trauma, it might bleed because of surgery, or it might have even bleeding spontaneously without having any kind of trauma. On this illustrated cartoon, you can see just falling down and causing severe clinical presentation. Let's have just a basic why lack of factor 8 is manifested by abnormal bleeding. Ideally, by our microorganism or by human being, the Lord is good, has made everything in place. So whenever you bleed in normal condition, there is a formation of a clot just to stop bleeding. That clot ideally is made because there is coagulation cascade. There is a lot of process that are done inside the vessel to produce a clot. One of those important factors that intervene to make a clot, there is factor 8. Just to make it more simple and for everyone, if there is any breach or if the vessel is ruptured, the second step of our organism is to try to contract and see if we can decrease the lumen of the vessel. Then platelets comes and make a platelet plug followed by factors related that are intervening into making a very strong clot. If those factors, I said, those factors, for those who have been, if you do remember your biology, there are different factors, but I would draw your attention on factor 8 that activates the most important common pathway to end up with generation of clot. So if that factor is not there to activate that common pathway, definitely you will not get a clot. So always we ask ourselves, why do we have a different behavior in terms of bleeding? So the bleeding or clinical manifestation is always related to the percent of that factor, which is the deficiency. So if it's very severe, meaning less than 1%, or you might have a moderate aspect of clinical presentation because you have a moderate or acceptable factor 8, which is range between 1 to 5%. It might not be enough, still deficiency, but the percentage or the concentration is bare enough, between 6 to 30%. You understand very well the clinical presentation or the severity of bleeding will definitely depend on that concentration of factor 8. I would draw attention on the severity because most of cases received, they are always so severe. So without even having any insult or trauma, they have a spontaneous bleeding because that factor is very, very, very low. You can have 2 to 4 bleeds every month. Imagine if you're a family, you have one child with that disease, how often you're gonna take your child to hospital? 4 times monthly, meaning you will not have time to work because you will be taking care of that patient or adult as well. So where do we expect to have bleeds? Bleed might come or might happen in any organ, unfortunately. Bleed might happen into joint, it might happen to muscles, it might be even life-threatening bleeding. Imagine if your patient is bleeding into brain, into chest, in the abdomen. So depending on the severity of bleed and where the bleed is being occurred. Most of the time, the patient with hemophilia bleeds into muscles and joints. Either it might be traumatic bleeds, might be after surgery, or it might just be a spontaneous bleed. In some condition, if there is no intervention, they might be even lethal, or you might lose your patient. For example, if he's bleeding into the brain, if he's bleeding into abdomen, like iliopsoas muscle or mesenteric bleeds, or if he's bleeding in the neck or airway. So you understand the severity of bleed might lead to accumulation of that bleeds and have effect on airway. End of story. So I would here show the most common muscle bleeds. Ideally, you might bleed in any muscle, but those are the most common sites for muscle bleeding. So we have upper arm on the triceps, you have deltoid muscle, on gluteal muscle, hamstrings muscle, or calf, muscle, and iliopsoas muscle. Depending on the nature of trauma, you might even have quadriceps muscle. So this means all important muscles that are involved in our daily activity might be compromised because of bleeding inside. That might be silent or occult, and so on. So we would like to show some cases that have life-threatening condition, like the one who bleeds into the brain. This one is a case with subdural hemorrhage. This one is the case with oropharyngeal and GI bleeding. If no intervention, definitely the airway are compromised. The last one was for intramuscular abscess. So if you do not treat your patient properly on time, you might end up with complication. Look on this picture. Already the hip is in permanent flexion, so it will be not possible to walk as others. This leg is dropped foot if you bleed into calf muscle. In some condition, you might bleed into on lower limb and leading to Volcanic contracture and have nerve pressure. So all movement will be restricted if those muscles are affected. So another challenge is when you have bleed inside the joint, and we know more than 60% of all bleeds in hemophilia happen in joints. So repetitive bleed into joint will definitely lead to abnormal joint with malformation or swelling. And when you try to touch, it is reddish, hot, tender, and very painful. Most of the time is suspected to have a septic arthritis or sometimes bleeding inside. If you're not smart enough, you might even try to puncture, and your patient will continue to bleed. So this is long term as well. You can see the patella is destroyed. So if they keep having repetitive bleeding, the entire articulation is fixed and the patient cannot flex no more. So you will having very muscle wasting of quadriceps, morning stiffness, chronic pain, and limited movement. This is a picture as well showing the severity of this case. Again, this is malformation or deformation of joints. So how do we, ladies and gentlemen, how do we diagnose hemophilia? Ideally is based on clinical and history taken. Most of the time there is a family history, bleeding tendency during circumcision, or bleeding at umbilicus with loss of cord. So most of the time there is a prolonged bleeding, especially in a hospital setting when you are doing heel stick. Or you might have other clinical presentation as previously discussed. For healthcare providers, there is only way to diagnose it based not on clinical. You can request some lab investigation, PT and APTT, and in some lab they might do a mixing study. If you're lucky, but currently this is available in at CHUK and other private lab as well. Factor 8 and factor 9 can be tested. So the hemophilia, how do we treat already a confirmed case of hemophilia? So we will just discuss a basic one, but the principle is diagnosis, then the treatment will be driven by the severity, acute, or we are facing a life-threatening condition, and what your target desired correction. Ideally, if it's mild bleed, we target to have at least 30% of factor to control that mild bleed. That can be achieved by giving 15 international units per kg as a slow bolus. But when it comes to a major bleed, definitely we need to have a high target around 100%, even more. That is equivalent to 50 to 100 international units per kg to be given as a shot or a bolus. So we depend on the case, but most of the time is for the case with CNS, the case that might need surgery, or those who have abdominal or retroperitoneal bleeding or GI. So this is how do we calculate it is quite easy. So depends on your target of correction and what we know, the factor, 1 unit of factor 8 per kg should raise your factor by 2%. So this was a case of 10 kg that we work out, it is around 500 international units if it's factor 8. So for factor 9, it's quite different. So the factor of correction is around 1.2. The same case, if it was a factor 9, we would be giving 1,200 international unit. So ideally, the factor infusion should not be so slow as we said as the bolus. Ideally, should not be more than 3 minutes per minute in adults. But when it comes to children or young adults, we should not be giving more than 100 international units per minute. So you have to calculate how much you're gonna give and respect the infusion rate. Besides of corrective factors, there are other important measures we should consider which have contributed and changed the practice is a RICE approach, which is rest, ice, compression, and elevation. The most important for those who are working in district hospital, if you receive your patient and you suspect, as you will not have factor, you have to put your patient on rest. Then if you have ice, we need to apply ice on the site of bleed, plus gentle compression and elevation of the affected limb. So we need early factor replacement whenever possible and apply RICE. What challenge are we having when we are treating patients with hemophilia in Rwanda? The most, as the deputy president of Rwanda Fraternity of Hemophilia has highlighted, we do have a late presentation and definitely with a delayed diagnosis among almost all patients followed currently. So there is community belief due to poor awareness. So they still think is bleeding because of family issue, belief of witchcraft, and so on. So another challenge is availability of factors, but luckily enough, we have been advocating of getting those factors in Rwanda through World Federation of Hemophilia. Unfortunately, it's not yet covered by insurance. So even if it comes, the hospital, CHUK has to pay some money because it comes directly to institution. And the insurance do not cover those factors unless it is other related hospital bill. So diagnostic capacity is still challenging at the district hospital level across the country, probably because we are lucky we have RBC representative here, so we should advocate to get those just simple tools at district hospital level. Ladies and gentlemen, thank you so much for your attention. I would draw your attention for this take-home message. The first one, bleeding is not a disease. So whenever you have a bleeding disorder, worth to get investigation and know why your patient is bleeding. So hemophilia, as we said, is a bleeding inherited clotting factor disorder that is worldwide known and common. Treatment is ideated by factor replacement and is long life course, is costly, so the community and the family insurance should intervene in order to relieve the burden on family with those patients with hemophilia. Good news we should share with you, currently factors are available at CHUK, and we have all means to make a proper diagnosis of it. Whenever you suspect a patient with bleeding disorder, we have 2 clinics at CHUK, adult site, and pediatric side as well. Almost welcome. So early detection and early treatment will change life of our patient and will be welcome, as because most of them, they come late and all complications are related to delay of diagnosis. Thank you so much, dear friends. Your comment, your question will be welcomed at the end of other presenters. Thank you. Have a nice day.
Thank you so much. I would like to thank you so much, Doctor, for the presentation. I can see in the comments below, everyone is appreciating. Would like to thank you so much for the nice presentation. We've really learned a lot. Right now, we are going to welcome the next presenter, but I would like to remind you that please write down all the questions you have in the chat below. We will get back to them. The professors can get back to them at the end of the session. And also remember to change your names from device names to your real names. I think that's it. So if you have any questions that you have for this course about hemophilia, please leave them in the chat below for the presenters and professors to get back to them at the end of the session. I would like to welcome Professor Masaisa, who will take us in the next session. I would like to request all of you to mute and so that we can follow. Thank you so much. Yes, as Professor Masaisa Florence is getting ready for the presentation, I would like to remind you to change your names. I can see some people still have Galaxy S70 and others still have device names. Please change your names to your real names so that you can be able to get the course modules at the end of the session and also be awarded certificates at the end of the session. Please change your names to your real names from Galaxy S70 to your real names. And also remember to mute so that we don't interrupt the professor as she's giving us the session. Yeah, I think that's it. So as some of you are not going to be able to join in later since the number is at maximum, you can be able to follow us on YouTube live on Health-Edu YouTube channel. If you're not able to get back in while you leave because the number of the participants is already high, please, you can follow us live on YouTube. Remember to change your names from the device names to your real name so that you can be able to get the certificates at the end of the session. I can still see TechnoSpark 2, TechnoSpark 5, TechnoPop. Please change your names to your real names. Also, write down the questions in the chat box below about hemophilia that you'd like to get answered on. We'll get back to them with the professors at the end of the session. Thank you so much. We'll give a few minutes to Professor Masaisa to get ready, and then we can follow. Thank you so much. I can see the questions already down in the chat box below. You can still send in more questions. We'll get back to them at the end of the session. I still see a good number of questions down below. Thank you so much. Keep sending in the questions, and the professor will get back to them at the end of the session. I would also like to still remind some people that still have device names on their phones, Galaxy S4 and Galaxy S7. Please change your names to your real names in order to be given certificates at the end of the session, and also course modules, because we cannot be able to identify you with the device names. Galaxy S20, please, and TechnoSpark 3, please change your names to your real names from device names. I think Dr. Masaisa is getting ready because we can see the screen on now. I think we can now welcome her. You're welcome, Professor Masaisa. Please take on.
Okay. Good afternoon, everyone. I'm Florence Masaisa. I'm a physician hematologist working at Seashika, taking care of people with a hematological disorder, including bleeding disorder. It's my pleasure to be with you today. Thank you for coming, and your attendance is very appreciated. We are going to discuss about other bleeding disorders. My colleague have spoken about hemophilia. We are going to go through briefly on the definition, clinical presentation of bleeding disorder, classification, what are the laboratory tests to do. We go to the summary, and that's what we're going to do. So by definition, you all know what is bleeding. So it may be either internal or external. You have to identify what is the source of bleeding? It may be either from the mouth, nose, urethra, or vagina, and you have to describe the site of bleeding. So why the bleeding occur? Usually it occurs from the abnormal hemostasis. If you remember well the step of hemostasis, we have the primary and the secondary hemostasis. The primary hemostasis normally include at the site of injury, we have the vessels wall plus the platelets, which will end by the platelet plug. Then the secondary hemostasis includes the activation of the coagulation factors, we'd end out with the formation of the stable fibrin clot. Then we'll see the dissolution of the clot, which is fibrinolysis. So primary hemostasis include the platelets and the vessels. It usually occur within seconds after injury. We have the platelet plug. Then for the secondary one, we have coagulation, which will form a stable fibrin plug, which will prevent blood loss from the large vessels. That is just a picture to represent what we have said. There will be, first of all, vasoconstriction. So the vessels play really a big role. The platelet plug and the coagulation cascades, they all together. Any defect on one of these may cause the bleeding. Just a summary to remind you what is the cascade of coagulation. We have the intrasect and the extrasect pathway. We have the common pathway, and we have the end of the coagulation where you see the fibrin, which is stabilized by the factor 13. Then you have, after the reopening of the flow, where you see the degradation of the fibrin product. So in details, bleeding can occur if one of these is affected. We have the vessels, we have the disorder of the platelets, which may be quantitative or functional. Any issue with the coagulation factors, either deficiency or inhibitors, then it may be also the combination of all these together at the same time. When you are assessing a bleeding, you have to get a clinical evaluation of the patient. You need to know either the bleeding is coming from the vascular, is it from the platelet issue, or the coagulation disorder. So at the end, we want someone to have an idea at least to classify either this is coming for which area, which investigation to do. Sometimes also the bleeding can be due to anatomical defects. Someone may come to you with GI bleeding, such as esophageal varices or peptic ulcer disease, which is bleeding. So the cause of bleeding may be anatomical. So that is also to be considered. So by classification, I said the bleeding can be due to thrombocytopenia, meaning that the platelet is low. It may be primary or secondary. We have no thrombocytopenic, meaning that either the vascular or the disorder of the platelets. Then among the coagulation disorders, we have inherited and acquired. So among the inherited, we have hemophilia, we have hemophilia A and B. We have also von Willebrand. So my colleague has spoken about that. For acquired disorder of coagulation, we have medication. So medication history should be considered. Someone with anticoagulation, warfarin or heparin, you have to consider that. We have also disease-related, in such of, in case of liver disease, vitamin K deficiency, in case of disseminated intravascular coagulation, or any fibrinolytic disorder. So these are the conditions which are acquired, which may also occur. Quickly on the vascular disorders, we may have congenital or acquired. Among the acquired, we have senile purpura. By getting age, the vessels can be easily fragile and be traumatized by any minor trauma, and someone may have skin bleed. We have vascular purpura, we have Enochian skull and purpura. So all these are the vasculitis. People may develop vessels, bleds or skin bleds due to that. From the platelets, we have quantitative or qualitative. So quantitative, the platelet may be either low number or even increased number in thrombocythemia. We have also qualitative, where we talk about thrombocythemia. We have Bernard-Soulier syndrome, and we have medication. Someone may be on platelet anti-aggregates like aspirin and may develop bleeding. So about this, we have said about disorder of coagulation. This is just a repetition. So when you are dealing with bleeding, you have to try to differentiate if the bleeding is due to platelet issue or coagulation disorders. So by the site of the bleeding, most of the time, bleeding due to platelet disorder, mostly it's on the skin, either mucous membrane like epistaxis, gum bleeding, vaginal bleeding, or gastrointestinal tract bleeding. So mostly for coagulation factors, the bleeding is mostly in the soft tissues, in the muscles, or in the joints. In the platelets, you have petechia, but for the coagulation, it's not. Ecchymosis are small or superficial in platelets, but are large and deep in case of coagulation disorder. Hematrosis, muscle bleeding are extremely rare in case of platelet disorder, but very common in coagulation disorder. Bleeding after cuts or stretch usually occur after platelets, and it's not common to see it in case of bleeding disorder. Bleeding after surgery or trauma, it's usually immediate if someone is having platelet issues, or in case of a bleeding disorder, usually coagulation disorder, it's delayed. It may occur 1, even 2 days after the severity. So after assessing your patient, we have what we call screening tests, which orient you to know what is the cause of the bleeding. We start by doing the full blood count, looking to the count of the platelets. So it will show you if the platelet is low or normal or increased. Secondly, there is a bleeding time, which usually assess the function, the function of the platelets. It will be prolonged in case of there is a thrombocytopenia or any defect of dysfunction of the platelet. We have also platelet function analyzer. We don't have it locally. Then you have also von Willebrand panel. Then to assess the fibrin clot, we have prothrombin time, and we have APTT, which we come in detail to see what these tests will assess. So bleeding time, as I said, will assess the platelet count and function. Prothrombin time will assess the effectiveness of the intersect pathway. It also assess factor K dependent factors. We have partial thermoplastin time, which will assess the intersect pathway. So you remember that hemophilia is among the intersect pathway factor. That's why it will be prolonged in case of hemophilia. We have thrombin time, which will affect, assess the conversion of the thrombin will assess the conversion of fibrinogen to fibrin. So it will assess the measurement of fibrinotic pathway. So I'm not going to go to the disorder of the platelets. It's usually a lot among the cause of the platelet issues. We may have dysfunction of the platelets when the platelets, we assess the bleeding time, which is prolonged. It's also assessed by the platelet function analyzer and also the platelet count. So we have different platelet disorders. We have, first of all, inherited disorders. Among them, we talk about Grandman thromboasthenia, which is a lack of or defective receptor or factor receptor 2B and 3A, which is a receptor to fibrinogen. So this is somehow diagnosed through flow cytometry or monoclonal antibodies. Locally, we don't have it. So anyone dealing with the platelet dysfunction, we may have difficulty in diagnosis that. So we have a Bernard-Soulier syndrome, which is also a lack of GIB receptor to von Willebrand. We remember the role of the von Willebrand. So by deficiency in this receptor, that will make also issue in the platelet plugging, causing bleeding due to platelet dysfunction. So we have a different platelet dysfunction. We may also have acquired one, which is seconded mostly for people taking aspirin or antiplatelet aggregation factors, like also non-steroid inflammatory drugs, which inhibit thromboxane-mediated platelet aggregation. Thrombocytopenia, again, can be due to different causes. We have impaired production in case of bone marrow failure. We have increased destruction in case of immune thrombocytopenia. So remember that antibodies destroying the platelets. We have thrombocytopenia in case of abnormal secretion. Some people with the huge splenomegaly and delusional platelets. After like a massive blood transfusion, you may have delusional thrombocytopenia. So I'm not going to all the details, the mechanism of destruction, the poor production of the platelet from the bone marrow include the leukemias, infection, inflammation. So all this may cause decrease in platelet. So abnormal secretion, again, we said about splenomegaly and massive blood transfusion. So when you are transfusing massive blood product, remember that you may cause like let alone you have to add also platelet transfusion to avoid dilution thrombocytopenia. So we have also coagulation disorders. This is the table we have repeated several times. Remember, inherited and acquired. Among the acquired, remember the history taking of asking the patient about the medication. He may be having a deep venous thrombosis, taking anticoagulant. So remember to ask the question about which medication the patient is taking. So the list is long. We have vitamin K, like antagonists like warfarin, which is commonly taken in the population. We have the heparin and so on. So those are the molecule we need to. So this table usually, most of the time you may meet people on warfarin, then they have developed either bleeding, considering the ENR they are presenting, which is monitoring item to follow if someone is on warfarin. So this table you will read it. It show you what to do in case of bleeding due to anticoagulant warfarin. So we have also heparin. Usually, someone with heparin, the reverse. Usually, you do supportive treatment with transfusion, but someone with fractionation warfarin, you may also give protamine to your patient. Coagulation factor inhibitors. Usually, you may have people developing inhibitors to factor 8 or to factor von Willebrand. Some hemophilic patients may also develop it. It's also common. You may find that. And you have also some acquired hemophilia. Remember that some hemophilia may be acquired. We have talked about that. We have also acquired von Willebrand disease, which also acquired due to antibody against Willebrand factors, which also may be seen. In case of von Willebrand disease, sometimes it's associated with the factor 8 deficiency. You may see a platelet function study to do bleeding time together with APTT, which will show you prolongation depending on the rate, on the level of factor 8 affected. So we have coagulation disorder, which is now acquired in chronic liver disease. So in chronic liver disease, literature said that about 15% of chronic liver disease may end up with bleeding, but this is not yet clear. It looks like the most of time the bleeding is due to low production of coagulation factor. Remember that all coagulation factor except factor 8 are produced in the liver, so it also affects the bleeding from the liver may be also anatomical in case of esophagovirus, in case of thrombocytopenia, and so on. So again, PT and APTT will help you to assess the bleeding pattern in the laboratory profile. My colleague have talked about in hemophilia. Among the inherited, the most common is hemophilia. We have von Willebrand, we have also fibrinogen abnormalities. We may have fibrinogenemia or IEPO. We also factor 13 deficiency. We have protease inhibitors, and we have vitamin K dependent coagulation factor deficiency. So all these can be assessed during the initial workup and the workup depending on the factors. So hemophilia has been talked, we have covered hemophilia, so I'm not going to repeat it. Just a quick word on von Willebrand. It's sensitized in the endothelium and megakaryocytes. It usually play a role as a transporter of factor 8, and also it's also autosomal dominant. It inherited autosomal dominant. The incidence is 1 to 10,000 on the population. The clinical manifestation may be between platelet disorder and coagulation disorder, depending on the classification of the von Willebrand. We see which stage may affect the bleeding factor 8 levels. So it's somehow in the laboratory, it's not single test to diagnose it. Locally, we don't have, in Sershika, we have, we can measure von Willebrand antigen and activity. But concerning the basic lab tests, you may find prolonged APTT, depending on the level of the factor 8. So especially from the type 2B, subtype 2B, that may also make a decrease in the factor 8 levels. So type 1, it's usually partial quantitative deficiency. Type 2 von Willebrand disease, it's a qualitative deficiency type. And factor 3 is quantitative deficiency. So that is showing you the easy to diagnose it. We have factor von Willebrand antigen, which is low in the first group, normal in the second, and decrease. So, but these tests are usually done at the teaching hospital and some specialized laboratory to do that. So in this table, you find more details about the subtypes, the clinical severity, and the laboratory. You are going to read it when you have time, and the frequency of the occurrence of the type of, the subtype of von Willebrand disease. So the management of that, in case you have it, you have a fusion of von Willebrand factor. In Rwanda, we still have issues to get it. But we are advocating to get it, if we can get it among the factor 8 and 9 factor, which is coming, still under negotiation. But when you don't have a factor 8, there is an option to give desmopressin, which usually sensitize the von Willebrand, which is under subendothelium. So you can give it when it may work in case of minor bleeding, but in case of severe bleeding, the factor is really needed. We have fibrinogenia and hypofibrinogenia, which is also among the bleeding disorder to be assessed, which is very rare, but among them, people may develop also hemarthrosis. So among the investigation you do, you should also remember the level of fibrinogen. Vitamin-dependent coagulation factor deficiency. Remember that vitamin K dependent factor are factor 2, 7, 9, and 10. We know that them. So there are different mechanisms of the deficiency, especially in the newborn. Remember that's why newborn are getting vitamin K after delivery. The risk is very high, especially for premature babies, but also adults may also develop it. We'll see later the mechanism. We have also factor 13 deficiency. So it's also another inherited disorder, which is now autosomal recessive. The bleeding can occur from the intra-articular, intraperitoneal, or the CNS, or in the CNS site. The bleeding, as you know, factor 13 come on the stabilization of the fibrin clots. Most of the time you see the normal bleeding time, the normal PT and APT should be normal because it's not really affected by the factor 13. So this is the summary of the factor deficiency which we can have. We have which is sex-linked recessive one. We have hemophilia. In case of hemophilia, the test you have to measure, we have a prolonged PTT with normal PT. In the factor 2, 7, 5, 7, 10 and 11, we have in the fibrinogen deficiency, we have prolonged PT and or APTT. So meaning that by doing your basic test, PT and PTT, that may orient you to screen the factors which may be having specific dosage in later on. So this is different. The table here summarizes different factor deficiency with the screening lab tests starting by ENR, PT, PTT, PTT. So all these help you to understand in case of this, what is this? So it may help you to, when you read it and you find some more details on that. So now let's talk about how do you approach someone with bleeding disorder. So bleeding disorder, it's really an emergency. You don't have to ask the patient, do you have an appointment? So it's really, the patient, whatever assurance, whatever transfer he has, it's an emergency. So don't ask any question about what, do you have an appointment? So that is not strange. So it starts usually by the history, the clinical examination, and the laboratory investigation. So starting by the history, you should be taking the history from the pattern of bleeding. Is it the bleeding after minor injury? What was the mechanism of injury? So if I bled after minor injury, so that is a problem. So the question should be oriented like that. So this show you that's what's the mechanism of injury. Falling down from long space, from the bicyclette. So those are really not a minor injury. So the question should be also considering that. So again, we have to ask about the family history. Remember that in some cases, someone may have inherited disorder without any previous family history known. So that was a problem. So you go back to the neonatal, asking the mother if it's a child. You ask about the intracranial or other site of bleeding at birth. Hematoma after the intramuscular vitamin K injection, as everyone gets injection of vitamin K at the birth. So you should ask that child, did he bleed that time? Bleeding from the umbilicus curve, excessive bleeding after circumcision. So you try to get the history of the bleeding from the past. Any history of bleeding after vaccinations should be also assessed, and history of easy breathing should be also assessed. So what are the common ways on which the patient may present? So the patient may present with epistaxis, gingival hematuria, hematoma, hematose. And remember what we have said before, bleeding from the platelets are mostly from the skin, mucocutaneous. Bleeding from the coagulation disorder may also may be from the deep tissue on the joint, but may also be on the mucocutaneous. So prolonged bleeding. So again, so either from the blood vessels, from the platelets, or from the coagulation. So you in this history should also try to identify the source of the bleeding. Bleeding from the vessels, you have you see the picture here showing you someone with vasculitis having purpura on the lower limb, mostly on the lower limb. We have superficial bleeding in case of platelet disorders. In case of platelets, by putting pressure on the site of bleeding, you may stop the bleeding by pressuring. And bleeding from the coagulation coagulation factor usually can be most often after trauma, can be also spontaneous depending on the factor, deficiency, and the blood from the muscles, joints, but also may have epistaxis, hematuria, and ecchymosis. And remember what are the basic tests to do. We also, sorry for the slide, which is not somehow the organized, we have to age of the symptoms, go back to the neonatal, to the adult where we can have even acquired bleeding, mucocutaneous or the factors deficiency, what are the frequency, what are the site of the bleeding, or triggers the bleeding. So we have said about the question to ask, immunization, medication, don't remember to ask about the medication. Any problem with previous surgery, so if it's a boy about circumcision, any emergency and whatever, any issue with the dental procedures, and ask us about messes. How many days do you go for messes? And remember also family history. We also have to consider the underlying systemic disease. Then we go through the physical examination, skin and mucous membrane. Where is the bleeding? Is it the muscle and joints? Are the patient having lymphadenopathy, hepatosplenomegaly, or PELA, meaning that the patient is having anemia? So we have mucocutaneous and we have muscle joint. So muscle joint again, which is part of the coagulation factor deficiency. So remember the laboratory testing, we have the first line screening tests, and the second line is specific to what you are suspecting. If you are suspecting hemophilia, you start by full blood count, normal full blood count, except in case of chronic bleeding or massive bleeding, the patient may present anemia, but normal platelets. Then you go for PT, APTT, you will find APTT is prolonged. You go back to the intersect pathway, you see the most common deficiency. You start by screening hemophilia. If it's negative, you go to other factors which may be positive. So this is just a repetition, we have said it. Remember all the also signs of bleeding in case of thrombocytopenia, in case of leukemia, liver disease, disseminated intravascular coagulation, you may also have bleeding. So that was the just clinical cases. We don't have time to go to the clinical cases. Bon, so in summary, identify a correct and specific defect or hemostasis by doing laboratory testing to establish the cause of the bleeding. Screening tests are platelets counts, PT, APTT. We have specialized testing to establish the specific diagnosis. Most of the district laboratory are not able to make it, so we advocate for the referral system to follow so that the patient do not spend most of time in the district waiting to the diagnosis. So better you transfer very quick if you suspect any bleeding disorder. Then red blood transfusion for surgical procedure or large blood loss may be done. So remember that clotting factor may also have hematuria, epistaxis, and bleeding. As I said, in clotting factor deficiency, they mostly bleed from the joints and muscles, but also they may also have similar bleeding as platelet disorders. So platelets disorder do not get muscle or joint bleeds. So patients with von Willebrand disease can have superficial and deep bleeds depending on the subtype we have shared on the table. So if the history of and physical examination are suggestive, so von Willebrand patient may have a normal full blood count with normal PT and APTT, but think about von Willebrand disease and ask for specific screening tests if you are suspecting a disorder. So this is our reference. We thank you all for your attention. We are happy to your feedback and question from you. Thank you so much.
Thank you so much, Professor Masarita, for the wonderful lecture and session on hemophilia. I hope we've all been able to get a lot from the session. I would also request each one that has not yet changed their names to their real names to change their names from device names to their real names. So change your names from phone names like Galaxy and Techno to your real names. This will help in the giving of certificates. And also would like to request everyone that has a question to put it in the chat box below so that we are able to answer the questions at the end of the session. Thank you so much, everyone, for the participation. I would like to welcome our last professor to give us a session. I'm going to welcome Dr. Diodini on the session on hemophilia. Thank you so much. You're welcome, Dr. Diodini.
Thank you very much, dear participants, for having you with us this afternoon. It has been a great pleasure to have subscribed on this course, which is actually going to assist people with breathing disorders to know where to get services from different stakeholders, ranging from medical doctors and the other therapists that assist these people who have serious problems. Today, we're going to talk about musculoskeletal disorders, rehabilitation in patients with hemophilia. My name is Diodone. I'm the one to present it. I'm a physical therapist consultant at CHUK. I've been involved in the rehabilitation for different conditions, but these days I've been privileged to have a partnership with the Rwanda Fraternity Against Hemophilia and the Novo Nordisk Hemophilia Foundation to go abroad and be equipped with the knowledge and skills so that this class of people can be really catered with different problems they have. Sorry for the disturbance, technical problems. Yes, at the end of this session, I'm assuming that the participants will have knowledge about the musculoskeletal disorders acquired from having this program. Identify the key impairments, activity limitation, and participation restriction attributed to aging with the hemophilia. Talk a little bit about the outcome measures used to assess musculoskeletal disorders, and then be aware of principles of physiotherapy management as people who are involved in assisting these people. So like the previous presenters have highlighted, when you have hemophilia, there is a bleeding which can occur in the joint or the muscle. This triggers the degenerative process characterized by change of articular cartilages and the other joint structures. So when affected with hemophilia, change, of course, will occur in range of motion, and then the muscles while you're trying to move. So it can help to assist the affection of the part which is been affected by bleeding. So the rehabilitation will including achieve prevention, slowing the rate of functional loss, improving or restoring function, compensation of lost function, and maintaining the current function. The ability to move is an essential element for health and well-being, and is central to what it means to be to get health. So people have been carrying different researchers, and then it has been found that between 35% and 50% of people with hemophilia report living with chronic musculoskeletal pain. So you would imagine somebody who's having a permanent pain, how would you feel in terms of promotion. Studies have reported between 50 and 80% of people with hemophilia, they do avoid exercises and activities due to pain and arthropathy. Physical activity interventions are encouraged as first-line management for those with long-term musculoskeletal conditions. So most of the research available right now, they mostly focus on pharmacology management. Very few emphasize on recommendations on other interventions, including physiotherapy. So to consider the patient with the hemophilia into the society, the WHO has suggested that having this patient be considered or being assessed using the ISAFE, which is the International Classification of Functioning, would be an ideal because it considers the patient as not having, not as actually it gives him a human rights more than impairment. So we have the body function, body impairments. So for the body functions, it is where we usually classify the intra-articular hemorrhage, which is greater than 90%. Then intracranial hemorrhage, which is bad. Hematoma, intramuscular hemorrhage, intraneural hemorrhage. Then when it comes to the impairment, it is where we find the decrease of range of motion, decrease of strength, edema, pain, decrease of proprioception, decrease of coordination, balance, deficit, decrease of endurance. Next. Excuse me for the bit will be coming soon. Excuse me. Yeah. Yes. Then in terms of activity limitations, we see where people will have limitation in lying, sitting, kneeling, standing, and other physical activities, functional activities like walking, self-care, house tasks. Children maybe not be involved in the leisure activities and sports. And then for participation restriction, people won't be able to go to school and then be involved in family life or social activities. So what happens when you contract hemophilia? So the typical signs that have been mentioned, I want to take much repeating on them. Like other presenters have just mentioned, the bleeding occurs in the joint, the muscle, and the muscle mainly. So in severe hemophilia, bleeding may occur without any reason. The bleeding can go on for days if not treated promptly, meaning early interventions is encouraged. So the bleeding may take into different joints, but mostly the knee, elbows, and ankles are most affected, especially in children due to fall and when they play, they may get into shock with others. So this is a cycle actually which happens when there is a bleed in the joint, it gets damaged, then the surrounding muscles do not perform their movement, then muscle becomes wasted, and then the muscle gets damaged, and vice versa. The muscle can be damaged and then go on. So for the acute hemorrhage, which is called hemathosis, actually in this stage, the patient feels pain, often preceding by tingling sensations, warm on palpation, just rapid joint swelling, joints held in a position of comfort, tender when touched on or moved. So there is a reduced range of motion, or gait or inability to bear the weight on the affected side. So this is the figure, how the patient would look. I would call you to pay much attention on this, because when we are dealing with such people in physiotherapy, sometimes we may confuse them with the other diseases that affect the joints, like rheumatoid arthritis and other affection of the joints. Be careful with that. That's why the multidisciplinary approach is called upon to rule out what is actually happening in the joint or the muscle. So there is a swelling actually, like we've seen on the picture, and then the movement is stopped. And so the bleeding slows after several days when the joint is full of blood. If not treated, the bleeding can lead to disabling arthritis in the joints. That was in the joint. Then when it comes in the muscle, the patient feels pain in the muscle when it contracts or stretched. And then the muscle tightens and limits the range of motion. So this is how it feels. I mean, it is seen during observation when assessing the patient. So there are some muscle hematoma that can be hazardous. For example, bringing to the thigh, gluteal muscles, like I've mentioned before. I'm not going to repeat that. And then, so when bleeding comes into the compartmental syndrome, the forearm, so there's what we call volcanic ischemic contracture. And you know that in physiotherapy, we sometimes meet such cases. So be sure that it is not coming from after the operation or the disease which has already established. So which means when there's such problem, the patient need to consult the real personnel in charge of that. So when the bleed comes in the braid, this one becomes serious. These are the typical signs that we can see: long-lasting painful headache, vomiting, changes in behavior, drowsiness, sudden weakness or crampiness of the arm or the leg, neck pain, stiffness, double vision, difficulty walking, convulsion, or seizures. So now, when it comes to the assessment, I would like to call physiotherapists attending on this session to pay attention to this, because during our interview, you should be able to differentiate the information you obtain for the patient from other common diseases and with what you may suspect as hemophilia. But for us, I think most of the patients we receive, they come from medical doctors or other qualified health personnel, which I think they're better equipped to identify whether it is a disease related to hemophilia or other conditions. So meaning the history taking is really crucial. And also we should determine the severity or irritability of the problem, and then identify the precautions you would take before taking anything from the toolbox. So when you examine the patient entering into your consultation room, you should observe the patient and then palpate him, and then see whether there is it is warm or whether there is increased temperature. So we see whether there is swelling or tenderness. For the joint, you see that there is a joint of motion which has been affected. And then you start asking the patient to do it actively and then passively, so that at the end of the day, you will find what we call comparable sign during the process of treatment. When it comes to the muscle, you ask the patient to contract isometrically, and then you carry on other obvious muscle atrophy around the affected joint. So, of course, when the muscle has been affected, the length of the muscle tend to be, it is also affected, most of the time shortened. Then you would are also required to assess that. For the neurological examinations, you actually look at whether it is coming from the brain. There are signs and symptoms that I've just shown you that could confirm whether the bleed is coming from the brain. But also, in case where there is involvement of the nerve, the following need to be assessed: the sensation, the reflexes, neural tensions, balance, proprioception, and coordination. So for the functional ability or activity of the living, you observe how the patient perform the task, like walking, stair, climbing, standing, sitting. Then the posture. Then you observe swelling and temperature elevation over the affected limb. For the other tests, when it comes to the knee, you test the joint laxity, and then if there is any discrepancy, because sometimes when there is a bone overgrowth, there is this tendency of having limbs which are not equal. So there are different outcome measures that could help you to assess the patient. There are a list of them. I'm not going to repeat them, but many times when the patient comes to the consultation room, there is an X-ray which has been taken to see whether there is any bone erosion. But many times, such patients, they go through MRI or ultrasound to see whether the affection has been in the joint or the muscle, so that you can rule out the real problem where it is. But this time I would like to emphasize on health joint, hemophilia joint health score, which is actually a validated instrument or tool, which has been validated to be actually very helpful and considered to be very sensitive for the extreme of good of poor joint health. So when it comes to physiotherapy treatment, we do have different means of treatment, like when it is in the acute, like at the scene of the bleed, this is what we can do price. So the patient has to be immobilized, and then when there is a nice around, you apply it just for 5 minutes at the joint which has been affected, and then you progress at 10 until as melt, and then you repeat it every 2 hours in case of there is a severe bleed. Then when it comes to the rehabilitation in subacute and the chronic stages, you have to follow whether there is a severity of the bleed, and then you consider the duration of immobilization, and then make the previous damage to the joint will make it less likely that the joint will return to pre-bleed state, so that the patient may go back to his daily activities. So rest is always advised when there is something wrong happening by sprinting the patient, and it has been found that is very beneficial at this stage. Thereafter, the gentle stretching of the muscle across the joint, and then repeat it 5 to 10 times, repetition of in 10 seconds, and then static contraction of the muscles. So when symptoms improve, once can start leaving the sprint for longer period of time. Then with the progression with the active exercises, hydrotherapy if the patient can afford, and then improve with activities using different means to see whether the patient is gaining more strength using what we call microfets. Microfets is a tool which is used to see whether when you are resisting a muscle of the patient, to see whether it's improving from grade 1, 2, 3, something like that. This one's going to be give you a good precision. To ensure that in case muscle bleeds, that's one regain for the foot and the muscle length, you have also to consider that. So retain the balance and proprioception in case there is a bleed in the lower limb, then improve cardiovascular fitness and endurance. Then after, eradicate the gates. This way, the microfet I've been telling you, you can go and check on the Google and then see how it is applied on somebody, so that you can measure the strength of the muscle, where it is being achieved. So physical activities to help the muscle being flexible, and then strengthen the joint surrounding muscles of the joints, help to maintain a healthy weight. So particularly for the children with hemophilia, should get regular physical activities and then check on them, because they should be do it safely. So that's why they should be wearing helmets while walking or playing, and they should most of the time avoid sport which brings much the contact of people to the other. So there's what we call the chronic pain. Chronic pain coming from having this problem for a long time. So there is a conservative management, including the serial casting to assist correcting the deformity it has arise, because I mentioned that there are patients who comes at the hospital at a late stage, and then these people need to be corrected. So be sure that they are casted with progression. These are a list of different things that you can read when you are at ease, so that they can help you at your workplace. So there are advices for children with hemophilia, particularly again. You should always protect them, especially at the knee, elbow, and then the head. Be sure that they use safely the belt and strap and the stroller to protect children from falling out. So you should also remove the furniture with the sharp corners or pad them. Then keep out of the reach of or locked away small or sharp objects that could cause bleeding and harm for the children. Use baby security gates to keep child away from stairs and the other areas where he or she could fall and then injured. Check the equipment they use it to play, and then all the possible hazard. Be sure that anyone who is responsible for a child knows that the child has hemophilia. Consider a child wears a medical ID bracelet or necklace. If the child is injured, the ID will alert anyone caring for the child about the condition. Of course, this requires a lot of energy to put in place this system. This is most of the time in the Western countries, but it can be also applied locally. So preventive strategies for the family education. Family should be educated how they could cater their family members or children who have been affected by bleeding disorders. So interdisciplinary management is very crucial when you work in different hospital settings. We should be able to establish this team so that we can assist these people really properly. Like today's session, where you have seen that it was a session which was supposed to be done by physiotherapists only, but we found that it is better to be as a team of physician, oncologist, hematologist, and other people who could assist us, like people having this condition. And you know that during the process of rehabilitation, the patient has to be involved at whichever cost so that it can improve better. So this is an algorithm that can serve everybody in 72 hours. What can we do? 3 days, subacute, or 6 months after. What can we do? What kind of physical activities can we encourage these people? Then after surgery, there are physiotherapists or other health care professionals who do fear to touch these people, saying that they may fall into stroke. But when you are well equipped and have read all the instructions, there is nothing actually that is prohibited from assisting these people. This session actually calls you upon to really cater for these people when they are in the area where you work. Don't have fear to touch them. If you do have worry, approach a medical doctor who have been trained or any other who has been trained. He can assist you. So for any questions or suggestion you do have for after this presentation, it is really welcome, and I really thank you for having paid attention to today's presentation. I thank you very much for your kind attention. Thank you.
Thank you so much. Thank you so much, Dr. Diodone, for the good presentation. Thank you so much, Dr. Diodone, for the good presentation. It was really nice, and thank you to all the participants that have been able to pay maximum attention and follow. Yeah, we've really learned a lot. Thank you so much. questions in the chat box so that we are able to, so that the professors are able to answer the questions at the end of the chat. Thank you so much for continuing to follow us. Right now, I'm going to welcome a testimony from a patient with hemophilia. I'm going to welcome Neo Kwagira Jean-Marie. Thank you so much. Please unmute so that you can be able to follow him, so that you can be able to learn something from him. You're welcome, Neo Kwagira.
Thank you. My name is Niyotwagira James. I want to talk in Rwanda in my story. Okay. Navutse nk'abandi bose nta kibazo kigaragara kuri njye. Mu myaka 5 nibwo natangiye kugaragaza ibimenyetso by'indwara ya hemophilia, ariko ntabwo twigeze tumenya ibyo ari byo. Uko nakuze niko n'indwara yagiye ikura. Maze kugira imyaka 24 nibwo nabashije gukurikirana biza kugaragara ko ari hemophilia. Natangiye gufata inshinge za fagiteri. Natangiye mfite fagiteri ya 0%. Nibwo aba dogiteri batangiye kunkurikirana. Ubu ngubu aho bigeze birashimishije kuko ntabwo nkigira uburibwe bukabije nk'ubwo nagiraga mbere. Nubwo wenda twabimenye igihe cyararenze, naramaze kwangirika ingingo. Amavi yose yamaze kwangirika, inkokora zarangiritse. Birumvikana umuntu wari ufite 0% za fagiteri byari ikibazo gikomeye. Ntekereza mbere byari ikibazo, ubu ngubwo ubuzima buri kongera kugaruka mu murongo kubwo kubona ubuvuzi bwatwegereye. Murakoze.
Thank you so much, Neo Kwagira, for the testimony. I think for all the others that have been able to learn something from Neo Kwagira, will be able to understand the symptoms earlier and then be able to check in with the doctors at an earlier stage. I would like to welcome Dr. Aimable to answer some of the questions that were sent in the chat box. Dr. Aimable, you're welcome to answer some of the questions that were sent in the chat box. Thank you.
Thank you so much, moderator, for allowing me this opportunity to give response to questions that have been asked during this presentation. All are very nice questions. So the first one was asked by Gasana. I'm not sure if Gasana is still around, but there was a question asking what difference between bleeding of Ebola, in the case of Ebola, and the case of hemophilia. So if we recall the mechanism of bleeding, as we said, so there are two mechanisms where you might bleed, okay? So the first one, as we saw, is bleeding disorder related to either issue of primary hemostasis and secondary hemostasis. So bleeding disorder related to issue of primary hemostasis and secondary. The second one is vessel-related, vascular-related. If the vessel has been damaged. So what happened in Ebola? So when the virus of Ebola invade your vessels, ideally by immune mechanism, the macrophages, okay? So the macrophage come and attack those viruses of Ebola. So whenever the macrophage is affected, so they start releasing proteins that trigger coagulation. So initially, the vessels are completely inflamed. So releasing those proteins called coagulation cascade, and the patient at the initial phase, they end up with formation of clots. That's why most of organs, they are depleted by vasculation. The blood does not enter into vessels. Later on, that macrophage affected start releasing inflammatory markers and nitrogen oxides. Those nitrogen oxides, they lead to massive vessel or damage, leading to external hemorrhage. That's why most of the time you're gonna see the patient bleeding from eyes, from ears, from any orifices, because the vessels aligning the mucosa are destroyed. They have external bleeding. But also, as I said, initial phase, there is overconsumption of coagulation factors and with imbalance of coagulation activators and inhibitors leading to microthrombi. So that's why in Ebola, your patient bleed because of overconsumption with imbalance between factor activation and factor inhibitors, leading to formation of thrombi, followed by vascular damage. That's why you have external hemorrhage in Ebola. So what happened in hemophilia, as we said, is lack of factor, okay? Either factor 8 and factor 9. That's why you end up with internal unless there is a very trauma and open vessels and you bleed without being able to make a clot. That is simple explanation of what happened in terms of Ebola and what happened in terms of hemophilia, as we said. The second question was asked by Dr. Francois, RBC representative, about update on genetics therapy for hemophilia. So there are a lot of research and improvement in terms of managing the patient with hemophilia since 19 1919s. So at the beginning, just I would like to give the background. So at the beginning, we used to give just blood products, FFP, cryoprecipitate came later, and the factor has been developed and started being given. Unfortunately, even if the factors have been availed, always there was a challenge. So research continues. After development of factors, there is a new product which is on market and currently will be available in Rwanda. We have already made advocacy for it. Hopefully in this year we might have it, what we call a macizumab, which is a specific antibodies that will come and assist those patients with recurrent bleeding and living in a remote area that might not even be possible to come to CHUK. So it was not stopped on developing that specific antibodies that contribute, that is given subcutaneous and improve the life of patient with hemophilia. The genetic therapy, genotherapy in hemophilia is on in a pipeline, but research is still ongoing, and there is the trial is still under phase 1, so it's gonna take time, but not soon. Probably it will be released, but currently worldwide there is no gene therapy. Research are ongoing and might be promising. So they are consisting of injecting a vector, a virus that gene might be able to produce or replace the defective or mutated gene. But I don't know when it's gonna come out. But with a good work with World Federation of Hemophilia, whenever is possible, we will get that gene therapy as well. But cross your fingers, I don't promising anything. Gene therapy is just starting, but it's gonna take a long time to be approved and be used in the community. Luckily enough, there is a new product that might be available soon in Rwanda. Mr. Vanga, very nice question. So he just chat and asked if factors are available really at CHUK. Can it be possible to be available then at zip line, where there is use of drone instead of referring the patient at the CHUK? I'm really happy to hear that everyone is now understanding the challenge our patients have been passing through for ages. So the aim, that's why this webinar has been started, is to see how we can increase awareness across the health or care providers. So first step, make sure factors are available. Whenever you want, if you have a patient around your hospital, please command those factors are available. You can keep it nearby in your health facility or health center or even district level. But keep that idea of helping the nearby patient across your health facilities. So sending it to Zipline, I don't know, but what we can say, whenever you need it and you have your patient either in health facility, either in a district hospital, please order as you order other medication. It is a drug. make sure you know where to get it. As you get ampicillin, as you get cefotaxime, as you get paracetamol, the way you get it, no, you can get it at CH, you can keep in your pharmacy. And need to be kept in a refrigerator that can keep cold temperature between 2 and 8 degrees. So it is not a medication you're gonna keep in the pharmacy as others. So you need to have facilities. The last, that was not mine. Girubuntu Evelyn. This question was asked by others. So the platform was saturated to a certain number. So they were registered, but they didn't be able to attend this course. So he was asking if we're gonna give certificate by just watching or following this course on YouTube and whatever. That is for organization, not on my side. So you have to work on it and give response to us. I think if not the last, there is another question. I don't know who asked it. Yeah, they sent just paper. Can hemophilia has direct impact on heart resulting in heart disease? The question is not clear. If you are the one who asked the question, you can raise, and the one who is coordinating can give you the microphone. Then you ask it your question, either in Kinyarwanda, French, or English. Can hemophilia has direct impact on heart resulting in heart disease? I don't know. So, is it in the chat box?
Yes. Giringiro John, I think he's asking if hemophilia has a direct impact on the heart and if that can result into heart disease.
Okay. So if I get where the question, is it possible that hemophilia can have direct impact on heart, resulting in heart disease? If possible, tell us more about it. So the response might be yes and no, and I will tell you why. Why do we have heart disease, and what do you call heart disease? Depend on the definition of heart disease. Either is the heart is failing. Okay. If yes, if what you call heart disease is heart failing, I will say yes, because when you have hemophilia and you bleed extensively, on and off, you might end up with anemia that can lead to heart failure. But saying it will have impact direct to heart, nope. Unless it's recurrent or chronic anemia, because patients have been bleeding without having enough blood. Otherwise, there is no relation between hemophilia and heart disease. Unless, if not clear, you can let us know what you would like to ask. Otherwise, that might be the response I can give. Response is no, unless you have chronic anemia. Chronic anemia due to recurrent bleeding because of hemophilia, yes. If not, no way. All right, one more question. Okay, there is one question asked by journalist Sabiti. So just to know how many cases so far we do have in Rwanda, referring to the data we have, I'm talking of the data of one institution. Probably other cases are not in the registry. So far, we have around 66 patients, okay, in our record. But that figure does not represent the true countrywide. Patient might be more than that. And we are trying to advocate, if possible, to see if the basic test should be done at birth. So whenever we have that possibility of making neonatal screening of hemophilia, we might have accurate data for the country. Otherwise, we do have data of one institution, and we do have many institutions across the country. So if no more question, I would end this session. Again, thank you for your nice question, and thank you for the willingness for helping those patients across all health facilities, and you will be contributing of raising awareness wherever you work and wherever you are. Thank you so much. Let me give the floor to the organizers to continue on address the final remarks. Thank you.
Thank you so much, Dr. Imable. We have one more last question from Josephine Mushinzimana. The question is, what about the practice we used to see in maternity service where each newborn has to receive vitamin K1, 1 milligram? Is it linked with hemophilia prevention or not? I think this question will be answered by Professor Masaisa. Thank you so much, Professor.
Thank you so much for the good question. As I said, after birth, especially for premature babies and neonatal, we have to give systematically vitamin K injection. It's not to prevent hemophilia, it's to prevent vitamin K deficiency. As you know, from the pregnancy, babies or fetus do not get enough vitamin K from their mothers, and their liver is not yet mature to produce vitamin K dependent factor. So vitamin K injection is given to prevent bleeding, which may be due to vitamin K deficiency during prematurity or in neonatal period. It's not for, there is no relationship with hemophilia. Thank you.
Thank you so much, Professor Masaisa. There is a question here on, can hemophilia cause any disability? I think that was answered in the two presentations that were shown, whereby you can see the disability caused, whereby some patients have a disability with their knees and other parts of the body. I think that has been answered to Ben Honore. Right now, as we are closing our session, thank you so much for attending and also complying with the rules. One last question from Ishime Anastase. I think Professor Masaisa can also answer that question, and then we can welcome the President for the last word. Thank you so much.
Thank you, Ishime, for the question. The question is to know if you suspect someone with bleeding disorders, what to do. So first thing to do, I think at different levels, you are able to get, as I said again, history taking is very good. If it is a patient coming for the first time in the context of any systemic disease or any other illness that may be due to either platelet disorders or whatever, you have to take your very good history. The first thing to do as a basic test to know what is going on is to do a full blood count where you see platelets. So the laboratory can do screening test for coagulation like PT and APTT. But after excluding platelet disorders by having cytopenia, you assess the clinical history. You'll see the liver function test is okay, the kidney is fine, because there are systemic cause of bleedings which should be excluded before thinking about any inherited or acute bleeding disorder or acquired bleeding disorder. We have also to think about the liver disease, which should be excluded, disseminated intravascular coagulation, which should be also excluded. After screening of all these factors or this disease, you should be thinking about inherited coagulation disorder, which may need some specific tests, which is not done at all district levels. So the better way is to stabilize your patient. Someone with bleeding should not be referred depending on the intensity of bleeding. Should be first stabilize and refer in the proper way. Again, as I said, again, history taking, how the bleeding is coming, what happened. So all this should help you to orient your patient accordingly. Then you can send the patient for further investigation at referral hospital where they can assess the cause of the bleeding. Thank you.
Thank you so much, Professor Masaisa. And I would also like to thank everyone that has attended. We are going to get our last remarks from Mr. Sylvester, the President of Rwanda Fraternity Against Hemophilia, to give us the last words as we are closing this session. Thank you so much. You're welcome, Mr. Sylvester.
Thank you. Thank you for all things you have done during this session, and especially on behalf of Rwanda Fraternity Against Hemophilia, we would like to thank you so much, all participants, or people who are in partnership with Rwanda Fraternity Against Hemophilia, physicians, all healthcare professionals, and people around worldwide who are aware of difficulties or problems of hemophilia patients. We thank you so much for having registered to this CPD course centered on musculoskeletal care pathways for patients with hemophilia in Rwanda. We thank you again for having made best choice, and we expect at the end of this session that you have already avoided all things or thinking relating to false ideas, false imaginations related to sociology in our families, between different teams in society. And I think now you are keen on knowing and managing well pathophysiology and the situation analysis and differential diagnosis relating to patients with bleeding disorders, and especially the musculoskeletal rehabilitation of patients with hemophilia in Rwanda. As we are aware of this, being an association affected by the problem of hemophilia, we'd like to tell you that we are enjoying much of your partnership, and we invite you to take part of Rwanda Fraternity Against Hemophilia as active members and advisors. We would like you contribute much to facilitation of sending patients to CHUK if necessary, or asking for factors via contact of Dr. Aimable, or just you can also contact the social team on the contact of 0788 41 4062, which is regularly available. And then we would like you contribute also to a new target of sending factors by airplanes instead of ask patients to move when they are suffering much, because as the blood is sent in different hospitals, the same medicine names or known as factors may be sent, and the instructions may be given to the physician who is receiving the patient. So this may facilitate everybody affected by hemophilia to get assistance and to be cared as good as possible. Then we would like to thank you so much, partners such as Novo Nordisk Hemophilia Foundation, which is financing these trainings. Let me tell you that this is not the end of trainings. We still have other trainings. This was for physiotherapists. Next time, we may have some training of physicians, of nurses, and we may go over this with the trainings with people who are called health care at our villages. Not healthcare professionals, but we can just say agent santé communautaire in French, or in Kinyarwanda, aba janama ubuzima. And we will go over that, teaching some lessons in schools, if possible, as now we are in problems with COVID-19, which interrupted all the programs we have started. Then I'd like to say, we love you. We pray you stay good, healthy, and best wishes for all of you during this weekend. Thank you.
Thank you so much, Mr. Sylvester, the President of Rwanda Fraternity Against Hemophilia. Thank you everyone that participated. We appreciate so much. You'll get the PPTs or PowerPoint presentations from the Health-Edu platform. And for those that were able to participate until the very end, you'll be able to get the certificates upon the evaluation. Thank you so much, everyone. Have a nice time. Thank you. Thank you so much. You can now log out. Thank you so much, everyone.